dissertation report with the title Understanding and Responses to Mental Health Disorders Among Religious Leaders in Kilimanjaro, Tanzania. So mental health disorders, these are conditions that affect individuals' capacity of thinking, regulating their emotions and behavior, and globally an important public health concern, as in 2021, nearly 1 in 7 people worldwide were living with the mental health disorders, with anxiety and depression being among the most common. So although effective treatment are available, many individuals still do not receive appropriate treatment. And in sub-Saharan, individuals may seek help not only from formal mental health services, but also from faith-based and traditional source of care. And therefore, the pathway to mental health care involves several different providers. Among these community source of care, religious leaders are particularly important. So these leaders are trusted, accessible, and culturally familiar within community figures. And because of this, individuals and families may approach them when facing emotional, behavioral, or spiritual difficulties. And therefore, they can act as an early point of contact in mental health seeking pathway. In Tanzania, mental health problem is understood through biological, substance use, and social explanation. However, there's still limited evidence describing how these religious leaders understand mental health problem and how they respond. And this takes us to a specific problem that motivated this study. So ideally, people experiencing mental health problems should receive appropriate and timely professional mental health care, and religious leaders can support this by recognizing a problem early, reducing stigma, and encouraging referral. However, access to mental health services in Tanzania is still limited by shortage of professional cares, limited facilities, and persistent stigma. So individuals who suffer these mental health problems may first seek help from religious leaders who are accessible, trusted, and culturally familiar. So the main concern here is not individuals seeking support from these religious leaders, but what happens after the first visit. So these leaders may either facilitate timely access to care or delay professional treatment, depending on how they understand the problem and the action they choose to take. So for example, if a mental health problem is understood only as a spiritual problem, professional assessment may be delayed and individual symptoms may worsen. So although different approaches have been suggested in Tanzania, like training these religious leaders and collaboration with healthcare services, still, these approaches remain limited in Tanzania. And more importantly, there is a limited in-depth evidence on how these religious leaders understand mental health problem and how they respond when these individuals seek their support. And therefore, this study was conducted to explore this gap and to inform culturally appropriate collaborations between religious institution and formal health system. So based on the gap identified, the broad question of this study was, how do religious leaders in Moshi Municipal Council understand mental health problem, the attitude they hold toward people experiencing them, and how do they respond when individuals seek their support? And this broad question was further addressed by focused specific question, including understanding of mental health problem, attitudes and responses toward people experiencing mental health problem. So based on the research question, the broad objective was to explore religious leaders' understanding of mental health problem, their attitude and responses toward people experiencing mental health problem in Moshi Municipal and Kilimanjaro region. And this had further specific objective focusing on understanding attitudes and responses toward people experiencing mental health problem. So this is a conceptual framework of the study, and it was adapted from two complementary theories. One was Joram Mental Health Literacy Framework, which focused on recognition of mental health problem, belief about causes and treatment, and attitudes towards people experiencing mental health problem. The second framework was Gateway Provider Model, which explained how these factors influence a trusted provider towards the decision or support of these individuals who experience mental health problem. So this was a qualitative exploratory design, and I chose a qualitative design because the main aim of the study was to explore understanding of religious leaders of religious leaders towards mental health problems and their responses toward these problems. So this study was conducted in Moshi Municipal and Kilimanjaro region because of close access of both biomedical and spiritual facilities, and it included Christian and Muslim religious leaders who are actively serving in Moshi Municipal. So I used maximum variation purposive sampling to sort participants, and variation was sought by faith, tradition, leadership role, sex, and years of experience. So a total of 18 religious leaders participated in the study, and sample adequacy was assessed using information power and saturation. So administrative permission was obtained from religious authorities, and written informed consent and permission to audio record was obtained from participants, and data collection was done through face-to-face semi-structured in-depth interviews, and it was between May and June. So interviews were mainly in Kiswahili and lasted about 48 minutes on average. So the interview guide was informed by study objective and relevant literatures and the two guiding framework, but also I had case vignettes representing depression, anxiety, and psychosis, which were helpful to compare recognition, perceived causes, immediate support, and referral decision. So after data collection, the interviews were transcribed verbatim, and Kiswahili transcripts were translated into English, and translation were checked against original Kiswahili transcript. The analysis used was a framework-informed codebook thematic analysis, combining both deductive and inductive coding, and Brown and Crack's 6 phases guided the entire analysis. So I also used Microsoft Word and Excel to support data organization, quotation tracking, and vignettes comparison, and also a second analyst reviewed the codebook, quotation matrix, and developing thematic structure. So the final analysis generated 5 broad themes and 21 sub-themes. So trustworthiness was enriched through credibility, transferability, dependability, and confirmability, and ethical clearance was obtained from MOA's Research Ethics Committee. Written informed consent was obtained from all participants. Confidentiality was maintained using participant code, and data was stored securely on password-protected devices. So the characteristic of my participant, I had a total of 18 participants. Christians were 10, Muslim were 8, 15 were male, and 3 were female, with different leadership roles and a range of 8 to 54 years of experience. So from analysis, these are the 5 themes, and these are the 21 sub-themes. All were organized under 3 objectives. So objective 1 focused on understanding, second objective on attitude, and third objective on responses. And I'll take you through them so that you understand the main pattern. So under objective 1, religious leaders understood mental health problem through recognition of observable behavioral changes, emotional changes, and disruption of daily function. However, early problems were difficult to recognize, and participants reported mental health problem to have multiple causes, including psychological, family, social, substance use, biological, and spiritual causes. However, these causes were explained as interacting and not mutually exclusive. And most participants supported medical treatment and spiritual care. However, it was difficult for the participants to know when to start professional care, and referrals are unclear to most participants. So here is the quotation number 6 that supports understanding of objective 1. That is, at the beginning, a person may just seem quiet or withdrawn. It is difficult to know whether they have mental health problem or are simply facing a normal health challenge. So under objective 2, the main pattern was compassion, empathy, respect for dignity, and hopeful view towards people experiencing mental health problem. And these leaders reported acceptance and non-discrimination as part of religious responsibilities. However, few expressed fear or linked mental health problem to moral weakness or weak faith. And most participants reported stigma and discrimination within wider communities. As you can see, this participant 18 emphasized on dignity among these people experiencing mental health problem. So under objective 3, religious leaders reported responding to these individuals through listening and initial assessment, spiritual support and counseling, and referral to professional care. However, there was no single fixed pathway, so some referred early and others provided first spiritual care and then considered referral later. And another important finding that emerged was continued support, which included family involvement, prayers, and encouragement to these individuals. And participants also reported a need of capacity building and collaboration with healthcare services. As you can see, this quotation of participant 3 shows that referral did not necessarily end religious leaders' involvement. So for vignettes comparison, each vignette was answered by 18 religious leaders, and these numbers are all descriptive. So as you can see, psychosis was more consistently recognized and referred than depression and anxiety, where the presentation was less visible and more often interpreted as worry or difficult life circumstances. So the take-home here was religious leaders were willing to support and refer, but early recognition, immediate safety concern, and timing for professional referral were less consistent. So for the discussion and objective 1 of understanding of mental health problem, religious leaders recognized visible behavioral and functional changes, which were easier to recognize than early depression or anxiety. And this was similar to the study done in UK, which showed religious leaders had identified mental health problems which were more obvious and severe, while a Peruvian study showed a different pattern, and this suggests recognition may vary depending on context and presentation. So, but also on the part of causes, religious leaders explained mental health problem to have multiple causes, including psychological, socioeconomic, substance use, and biological causes. And this was similar to a study done in Tanzania, which showed that biomedical and spiritual explanation often coexist. But also participants viewed prayers, counseling, and professional health care as compatible, but the order of care and timing of referral varied. And this was similar to the study done in northern Tanzania and Kenya, which also highlights plural pathway and the need for clear referral system. So the main issue was not rejection of professional care, but uncertainty about when and how spiritual and professional care should be combined. So for the attitudes, religious leader mainly described compassion, dignity, acceptance, and hopeful view toward people experiencing mental health problem, while also recognizing stigma and rejection in the wider community. So this was similar to the study done in South Africa and Ghana. And for the part of responses, religious leaders reported listening, spiritual support, referral, and continued support, which suggests that they may function as potential gateway providers by influencing whether people are linked to professional services. And this was similar to the study done in Uganda and Kenya, which showed faith-based providers can refer and collaborate with healthcare services. However, this collaboration may be affected by weak feedback, difference in how mental health is understood, and unclear referral pathway. So therefore, the findings suggest that religious leaders can complement professional mental health care, but their gateway role requires clear referral pathway, clear role boundaries, and communication with healthcare services. So the additional input here from this study was continued support after referral, which emerged from participants' account and extended the gateway role beyond initial referral, as religious leaders may remain part of the person's spiritual and social support network while professional care continues. So the overall findings suggest that being a trusted first contact does not automatically make a religious leader an effective gateway provider. Their potential gateway role also depends on recognizing when professional help is needed, having a clear role boundary, and being connected to accessible mental health services. So the main strength of this study was to it explored an under-researched topic in Tanzania, but also included both Christian and Muslim religious leaders, and also included deductive and inductive analysis, which helped to retain framework-informed and data-driven findings. However, there were several limitations. The study was conducted in urban Moshi municipal, and findings may not be transferable to rural setting or other regions. But also referral intention did not confirm completed referral or service access, and responses may have been influenced by social desirability. So in conclusion, religious leaders recognized visible behavioral changes and disruption of daily functions. However, early or less visible emotional problems were difficult to recognize, and they described multiple interacting causes of mental health problems, and most viewed professional and spiritual care as compatible, but the sequence of care of which should begin first was difficult, and referral pathway was not always clear. So attitudes were mainly positive, and while most participants reported community stigma was wider within community, and religious leaders may act as community gateway provider, but their role should complement and not replace professional mental health care. So based on the findings, I recommend religious leaders should receive brief practical training focused on early recognition, immediate safety consent, supportive communication, and clear role boundaries. But also there should be a clear referral pathway developed between religious institution and mental health services, including updated service information and designated contact. And for the future research, should also evaluate whether structured collaboration between religious institution and healthcare services improves actual referrals and service use. So those are the references, and thank you for listening. Hello?
You.
Yeah. So that is my presentation.
Awesome. Thank you so much. That was really interesting. Anyone with questions or comments, feel free to unmute or put in the chat.
I can start us off. Thank you for that presentation. And I had a couple of questions on it. I think it was in the methods when it said that you didn't get to thematic saturation until 18 interviews. I'm wondering if you could talk more about that, because typically we see, or I've seen, I'm not a qualitative researcher, but that thematic saturation happens earlier. And then the other question is, did you see any differences between religious leaders, the Christians versus Muslim religious leaders, and would you have any recommendations that stratified between the two?
Okay. So first, I did not look for the differences. That was not the aim of the study. As you can see, my specific objectives just focused on understanding attitudes and responses. So I did not aim at all for the differences. And if so, if I needed to do that, maybe I should have changed the design and looked for the saturation in both groups. So for the first question, come again, was it about saturation?
About the thematic saturation being at 18. I guess
Okay.
you didn't see it earlier.
Yeah, I did not see it earlier.
Okay. I think too, maybe even though it wasn't your primary objective to look between the two different religions, you might be able to do so if you have each interview, categorized as, was this a Christian versus a Muslim? I just think those type of nuances are probably going to be really important to look at if you can.
Oh, unfortunately, I cannot, because my main point was just to obtain wide range of perspective and not the differences. As I said, if I want to do the difference, then I have to go back and look for different saturation between these Christian and Muslims. As you can see, the sample size for the Christian is 15, for the Muslims, just 5 of them. So I think comparison maybe it could be a little bit difficult, unless if that is my purpose, then I have to change the entire design of the study.
Okay.
I think it's a good point, maybe something to keep in mind for the next steps. Like, let's say if you were to pilot some kind of referral intervention, it would certainly be something to monitor to see if there were any differences, I think, across the different religious groups. I would be curious as well to see any difference.
I agree.
Other questions or comments? One thing that I'm wondering, and I don't know if you explored this maybe in any other existing literature, or Ryan could potentially have insight, because I know that his interest is often the intersection of the mental health and religious worlds. Of, you know, when I think about your recommendations, I'm wondering about the acceptability of the population of these flocks, because I can imagine, I mean, I would get, let's be optimistic and guess that it's high. But I can also imagine that there are some reasons why this population would turn to these religious leaders, and not necessarily somewhere else. So I'm kind of curious how their sense of confidentiality or trust could be impacted by these things. And I suppose, you know, of course, it goes to what kind of intervention you're talking about. If by referral, we're talking about making a suggestion to the member or to the patient, that's one thing, but doing any kind of external referring to pull in the mental health professional and identify that this person has this challenge, of course, that would be a different issue. So I'm wondering what we know, especially in this setting, if anything, about that next step, because I would be wondering about acceptability of the individuals affected. I know that's beyond the scope of the current study, I understand. Any thoughts?
Acceptability, I'm okay. I'm not sure how acceptable it will be, but
Right.
as these people are trusted by the community themselves, I think what I was thinking for myself, like not taking professional care into religious, but religious leaders referring these people to professional care.
Right.
Yeah. So I think that will be more accepted because these leaders are purely trusted with these individuals. So I think anything they suggest, it's high likely they will take it compared to other people.
Yeah.
Yeah.
That makes sense. I wonder, Ryan, if you had anything to add on some of the other stuff you've been working on.
Yeah, thank you. And this is a great presentation. I did interviews with actually mental health workers about this issue, so kind of the other side. Also some religious leaders, but with the mental health workers, it was really interesting to see. I mean, a lot of times they are actually informally referred by mental or by religious leaders, and some of the mental health workers were saying, like, religious leaders will often sometimes like accompany their congregants to the counseling sessions, things like that. But similarly, talked about like the lack of a structured referral system. All of it is kind of on an informal basis, and so it's kind of interesting that that was also recognized in your study. I found that really interesting. I wanted to ask if in your interviews you asked anything about like knowledge of the resources that were available. Did the religious leaders you interviewed know about resources in the community for mental health? Were they kind of aware of that to make those referrals, or did they just not know anything about some of those informal referral pathways that might already be there?
Okay, I did ask about that, and most of them reported to know about these professional mental health care people, but they did not know clearly how this leaf fellow works. and they did not have a contact person. Like, who should they go to ask about this? Who should I contact when I face this challenge? So the entire referral pathway was not clear to them. They did not know at what point are they required to even refer these people. So to them, they just thought like, if maybe I prayed for these people for several times and then this is not getting better, so they just decide to refer, but they do not know what to look for and when should they collaborate with these professional healthcare. And more importantly, they do not know, if I go to the hospital, who specifically am I looking for? Who should I check? So even if they suggest, they just say, just go to the hospital, you just get treatment there. So I think even that remains vague, because for an individual also, just go to the hospital and maybe just see a general GP. And then maybe from there, it's difficult to know what happened after that referral was recommended.
Thanks. Any other thoughts, questions, comments? I'm wondering how far you all are with developing a manuscript. Can we see this published soon?
Yes, currently I'm working on my manuscript, so I'm hoping to publish it soon.
Awesome. Well, we look forward to seeing it. A last call for comments or questions?
Okay, I have a question. I don't know.
Please.
First of all, Geraldine, this is amazing work. Thank you so much for sharing this amazing work with us. And I was wondering if you, during your research, do you see anything positive in how leaders act that we could apply in medicine with our patients? Because the contact, how the religious leaders do with patients, sometimes we, like doctors, we don't are able to do the same, or sometimes we don't know how to do this. And I looking for if you see anything, then could you think about this, please?
I haven't got your question clearly. Like, can you please?
I think the main question here, Bruna, is that you're saying, what are some things that you saw from the religious leaders that you think could be useful lessons for the medical professionals in terms of the way that the religious leaders deal with these mental problems? Because sometimes the medical professionals themselves have their weaknesses. So what can we learn from the religious leaders as medical professionals? Is that it, Bruna?
Okay,
Yeah,
so I think, okay, so what I noticed from these religious leaders, I would say they are less non-judgmental, more empathetic. They are welcoming. Then, like, they take time, I think, to listen to these people as compared to doctors. Maybe, I don't know, to your countries, but in Tanzania, I think a single doctor can see even 50 patients at a time. So normally we don't get time to sit down and talk with this patient and listen what is going on, as compared to religious leaders. They do have time and they are more empathetic. They take the entire time to listen to you and understand what is going on in your life. So for Tanzania, I think that is something that I would say it's different between doctors and religious leaders. And I think even the stigmatization also, when these individuals go to the hospital, they are seen as people who have lost their mind, as compared to religious leaders. With religions, it's like we welcome every person who has a problem there. That is quite different when you go to the hospital. So I think that's the main difference. Maybe doctors should also have time to listen to these patients, which then you have to increase the number of doctors, which I don't think it's possible, but yeah.
Yeah,
Ideal.
that would be
Thank you
ideal.
so
Yeah.
much. Thanks so much.
Great question, Bruna. Thank you. All right, everybody join me in thanking our guest. I really appreciate it. And good luck with the publication, Geraldina.
Thank you.
Congratulations on the work.
Thank you.
All right, now we will finish our recording and we'll move to our normal